Lupus. So join me in welcoming Dr. Van Warren.
Thank you. Thank you very much. This is after an introduction like that, I kind of wonder if I can walk out of here with my head still not being too large. But now this is kind of be a kind of informal, but it's I should say it's informally informal. This is because we're going to do a little bit of a presentation here, and I'm going to try to do it succinctly. But if you have questions, you can feel free to interrupt. That's the reason I'm saying it's informal. And then there are some things we wanted to try to do with this talk to try to, first of all, talk what in the world is lupus, and then we'll have to give a little bit of a history, a little bit of a background of lupus, but I'll probably spend a little bit more time on the pathophysiology. Yeah, we know that lupus is an autoimmune disorder, and that your immune system is set up to try to, for normal immune system, is set up to try to fight off foreign pathogens, whether it be viruses or be bacteria or some other things. But it's not with lupus that your body tries to decide that that immune system is that even parts of your own body are not what's supposed to be there. There are different types of lupus, actually. There's a cutaneous lupus, that's lupus limited to the skin. There's systemic lupus. There's a drug-induced lupus. We may mention a few things about that. And then the neonatal lupus. The cutaneous lupus is lupus limited to the skin, and there can be different presentations like malar rashes, the subacute cutaneous lupus, discoid, there's the tumoid lupus, there's paniculitis, there's photosensitivity. This one here is a demonstration of that malar type of rash. It's basically a rash, is a photosensitive rash affecting the skin. This same type of rash may be at other sun-exposed areas as well. This is an example of subacute cutaneous lupus. One, it doesn't form any scarring. So there's the patients that may have this, these can heal up and may only leave like little marks on the skin, but it doesn't cause scarring of the skin. This is only one presentation of some of it looks like little targets or rings. This is one that's that's a little bit more invasive. This is more of a discoid type lupus where it actually invades from the superficial skin down into the deeper layers of skin. This does tend to leave scarring. It tends to, if you had hair in that area, that hair is going to be gone because it tends to go deeper than the hair follicle. This is a form of which may be difficult for us to see. I don't know if you can see it, but it's called tumoid lupus. This is basically in the side of the nose here, and this is lupus that affects the skin, but it's deeper to the skin. It doesn't tend to cause superficial skin. Not only that is that but it's that not only that is it that many times patients may have this and not have any other form of lupus at all. It very rarely does it ever progress to systemic lupus. And one of the reasons is where that dark arrow is. You see that it's below the skin layer, that purple or bluish colored layer at the top is the dermis of the skin, and dermis and epidermis. This is all affecting below that level. So these are patients that if you look at them, this was a darker skinned person. But if you looked at a person that was more light skin, it tends to be more of a bluish hue to the skin. This is a more aggressive form of lupus. This is some people call it lupus profundus, but it's also called the lupus paniculitis. This is involving the fat layers of the skin. And this just gives you a little bit of an indication of that. It's just that you see the outer layer of skin, and this part was not really affected very much, but the fatty layer with all these white spots in there, that's where the fat has become atrophic and is being basically dying. And the layer of skin above it tends to sink in where that fat layer is dead. This is just going a little bit of an overview of what kind of medications may contribute to this lupus. And drug-induced lupus is not very, it's not, I wouldn't say it's very common. We do see it sometimes, but this tends to be a more temporary form of lupus. It tends to occur within like the first 6 months or maybe a year of taking whatever medication it is, but it may last or it may not occur for like several years. You may be on a drug for several years before it starts to happen. But now the good thing about this, in majority of patients, if they don't have underlying lupus, it tends to go away after stopping that medication. It may take 6 months to a year to subside.
So it's reversible?
Most people it's reversible.
Oh, that's awesome.
This is that, it's only a small percentage of people that have this type of lupus. So,
I have a question about
yes.
cutaneous
Mm-hmm.
lupus. do they go to dermatologist first and then they
Probably a lot of
refer to
people,
you, or?
most people probably into dermatologist first. You know, but sometimes I've seen one patient come into the office for something else, and we kind of picked it up on that. Just looking at that, and that something else she came for is probably also related to that lupus. So, now, but the cutaneous form of lupus that that sometimes can be tricky because there's rosacea they can mimic it. There's people that with acne can people with acne sometimes can get it. People there's a form of lupus, skin lupus called bullous lupus, they may present to they'll probably go to the dermatologist first before they ever come to see us. And this is that. But here's some of the medicines up here. Medicines are used to treat tuberculosis. There's some of them are used to treat high blood pressure. Some are used to treat cardiac arrhythmias. And some of these drugs are actually used to even treat other arthritic conditions, especially rheumatoid, like this tumor necrosis factor, psoriatic arthritis is used that. But sometimes people actually develop lupus because of the medicine they use to treat the other arthritis with. This that there's anti-epileptic medicines that can cause it. There's medicines that are used to treat nausea, that chlorpromazine. Yeah, that can, some people develop lupus from that. Then there's a sulfasalazine, one of the drugs that we use to treat rheumatoid arthritis and psoriatic arthritis, also is used to treat Crohn's disease, can also cause drug-induced lupus. Then the one drug, I put that down at the bottom because I've seen two cases of this, and it's people who are abusing cocaine or using cocaine that was laced with this worm poison called levamisole. And this is that I saw that patients actually develop vasculitis. One ended up having to have one leg amputated, and the other one ended up having both legs amputated on the basis of this drug right here. So this is that because of secondary infections. Because it's a very potent inflammatory condition for blood vessels. And if those blood vessels get inflamed too much, they reduce the amount of blood flow that goes through it, and then you can end up with gangrene and various degrees of necrosis because of that. This is that the etiology of lupus is actually kind of difficult to really put the finger definitely on it. But we notice that in the United States, about 20 to 150 patients per 100,000 people get it. This is that, and that's basically that more like the prevalence of it. But I bet the incidence is probably even greater. And we see that in Caucasian, there's about 164 per 100,000, and you see that people of African American descent is actually almost 3 times that. And this is the gender seems to play a lot with lupus also, and it seems to be hormonally related. And one of the reasons we can say that is that you notice that in young children, before they produced a lot of these hormones, sex hormones, that their the incidence is not that great in terms of female to male ratio. It's about 3 to 1. But then when you get to adults, that it's about 7.5 to 1. As a matter of fact, some people even say even 10 to 1. And then older adults, it starts to decline again, as the hormone levels tend to drop. And it's about 8 to 1. And just that there have been some suspicion about genetics in terms of this, but one of the big things that we hardly ever see anybody with Klinefelter's, men with Klinefelter's disease, but we see that they tend to have a higher prevalence of lupus, and you think it's because they have that extra X chromosome that makes it more of a female-oriented type of condition. And then you see ladies that are missing one of the X chromosomes, which is the Turner syndrome. You don't you don't see it that often, but you also don't see in those patients lupus being developed too much. This is the age of onset is generally between like 16 to 55 years of age, but the majority of patients we see that are probably about, I'll say, between 16 and maybe 20 years of age for onset. This goes a little bit different from the slide that I have here, but I'm looking at the patients I've been seeing in practice. It tend to be a little bit more on the younger side. And but we do see some patients that develop it, in their 40s or 50s or even later, and some suspected that maybe some of these may have actually had lupus for a longer time than they really realized it. And that this didn't have enough symptoms to go investigate it. We noticed that also black females, they tend to have an earlier onset than their Caucasian correlates, and then black men tend to get it a little bit later than that, but white men tend to get it even later. But it's that so anyway, because of this, there's a kind of a spread in terms of age group in terms of what lupus is being presented. That this one is a slide I want to get more to. This one, this is that lupus in children. Because we see some patients that develop lupus before the age of 16 or even before the age of 18 in particular. But they tend to be a little bit more aggressive lupus in the younger group of patients. It also turns out that in men, it tends to be a little bit more aggressive than it is in females on average. And we think that maybe some of it is because of the gene, or not the gene, but the antibody they tend to develop. And they tend to have more anti-SM antibody, more anti-RNP antibody. And it's that the men also tend to have a higher incidence of neurologic involved in terms of psychosis and hallucinations. There's some of these, there are people have looked at some of the genetic factors, and I'm not going to look at I want to pay more attention at the bottom of the slide. And this is kind of an interesting one. These are markers that are on the cell wall of your cells, and through these cell walls that sometimes your body may make antibodies against certain targets on that cell wall, and that was that toll-like receptor number 7 and toll-like receptor number 9, one for the DNA and other ones for RNA. And this is so we have your body may have been exposed to RNA type viruses, or it may have been exposed to DNA type viruses or other bacteria that resemble parts of your own body. So your body is over there thinking it's fighting off whatever bacteria or whatever virus, but it seems it's so similar to your own body, it also starts to attack you too. And we think that may be one of the environmental causes for the environmental factors that may be related to this. There's a second one is actually a slide that's important too. And we see that some patients are actually missing or have a deficiency of certain proteins, especially that C1q. And this is one of the proteins that tends to start the cascade for your body to fight off whatever organism that's been, or whatever pathogens that are attacking it. And the reason I want to call it pathogens, because this is one of called the innate system, or that it tends to be one of the earliest systems that your body uses to fight off infections or things that are not supposed to be there. But if you have a deficiency on that, sometimes you can't get that system activated. And then so that may cause difficulty with trying to fight it off in other ways. But I'll get to that in a minute. I'll show you. Yeah, this is that. This we're talking about the pathophysiology of lupus. This is one of the slides. We're looking at the clearance hypothesis, and it's basically thinking that if you're looking at that apoptotic cell, basically a dying cell, it starts releasing chemicals into your bloodstream. Your other cells, or your body white blood cells, T cells, tend to recognize that, and they start to produce, or the T cell stimulates your B cells to try to produce antibodies against those things and try to clear it out. But some patients have a deficiency on that, and those chemicals are not cleared, and their body may develop a tolerance to that chemical and basically ignore it for a while until we get an overwhelming amount of that particle or that chemical into the bloodstream, and then you start to cause a more severe or more aggressive type of reaction to it. And this is the top is basically looking at one of the drugs on how it tries to interfere with that. But I wanted to look right at the top of the slide, just kind of going over what we talked about. And it's basically that these white blood cells, when they get activated, I just tend to release something called B lymphocyte stimulator factor, which is a chemical that actually makes these cells live longer than what they should. They have a natural history. The cell becomes activated, that does what its job is supposed to do, then that cell kind of basically dies. But with that B lymphocyte stimulator fact, that cells that are affected by lupus tend to go longer and longer, live longer and longer, and keep that lupus drive and that lupus along. And so this is one of the drugs that are used to try to inhibit that B lymphocyte stimulator factor, so that it doesn't kill the cell, but the cell lives its life expectancy, then dies, and then hopefully the new cells that come along won't be as influenced by that as much. And then this is basically, I wanted to show that antibodies are not limited to just lupus. There are other conditions that may have a similar pathophysiology as lupus, and one of them happens to be Graves' disease or hyperthyroidism. A lot of those people also have antibodies against the thyroid. Myasthenia gravis, that is an antibody related to the thymus. We have people with autoimmune thrombocytopenias. They may have antibodies related to that as well. The one big one in the bottom part of the slide, that mixed cryoglobulinemia, we tend to see that with hepatitis C. Then this is what I wanted to leading up to with that other slide with these proteins. We're basically looking at that classical pathway. That pathway is that C1q C1 is basically being the initiator of that pathway, and then it leads to that protein which is called C4, which joins or binds to C2. C2 becomes C4 C2 becomes a convertase, which activates the system and then drives it on to fighting off whatever bacteria or whatever, because these proteins actually tend to attach to whatever organism it is and actually like drill a hole in it and then have the contents of that cell released into the bloodstream. And then once that starts to happen, that can activate your immune system to attack that more. But then we have that C3A that's also, it actually is an inflammatory thing that tends to cause more inflammation and also tends to recruit more cells to that wherever that spot is that's being affected. So that if you're missing that C1CQ, you have no way of really regulating the rest of this system. So this system becomes more activated, and then it even becomes active even when it's not supposed to be. And it's one of the reasons that some patients with that deficiency even if they don't have lupus, they can have features that look just like lupus because of this. So this was a very interesting kind of phenomenon.
Now, all I would have to say is all these deficiencies, how do we replace them?
Well, actually, if you figure out how to replace them, then you'll be taking my job away. But this is but one of the things that we see that some of these are deficiencies are development or acquired deficiencies, and so that if you can control whatever caused that the system to be activated, then your body can get a chance to try to rebuild its own proteins. You see patients that have okay, and so that I wanted to just skip ahead just a little bit because I see that my time is running low, and this is that we got that I wanted to get some environmental factors, but it also in the bottom talks about some of the genetic things. But this is one of the slides I wanted to point out is that you may have lupus activated in one part of your body, but you got a circulatory system that kind of carries things everywhere. So that why do some patients with lupus have a central nervous system involvement? They may have antibodies or other proteins that are directed to those cells that are inside the brain or in the peripheral nervous system, like your hands or your legs or your fingers. Just that, but those that can be affected. But it also can affect the heart if you have if you have antibodies that are directed to the heart. It can affect your lungs because you got the circulation system that's going all over your body. And then this is the immune complex. So I like this because it shows you that the fight that's going on with this thing. And this is that these are proteins that we're talking about, this C1q, C3, C4s. They tend to bind to other proteins that activate that system. And then once they're activated, you can have all these cell lines that can be affected by that system. But the one system that I wanted to talk about that I don't hear talked about very much, and that's that T regulatory cells. And these are the cells that kind of direct these other cells in terms of becoming active and then also then standing down when the activity or when the process is finished. But we think that some of the patients with lupus, these T regulatory cells are not doing what they're supposed to be doing. And so when that system gets activated, it just stays revved up, and that the T regulatory cells are not trying to calm it back down. So I think this is one of the things we need to research and try to figure out how we can regulate this too. And then these are showing about that co-stimulation of those cells. And basically, if you have a cell that's being activated and by say a pathogen is there, and if that pathogen is the only thing that's there, and the T cell tells that B cell to start to do something, if it doesn't have a second stimulation, that B cell doesn't get activated. And so one of the ways we can try to control lupus is that maybe we can block that second stimulation, and so that we can kind of inhibit that cell becoming overly active. But you got to be careful because those B cells are not just there to cause lupus; they're also there to help you for other reasons too. So sometimes we can overtreat and predispose you to different infections. And then this is I've talked about that a demonstration of how that the lungs can be involved with this, because this lung almost looks like a liver. I don't know if anybody eaten liver, but I don't think I want to eat this. This is one of the younger people with that Mailer type of rash, so there's skin involvement, which we showed some earlier. But this is the one that I wanted to look at, is that you can get one of the manifestations of heart involvement with lupus, and that sometimes you develop these nodules on different, either the outer side or inner side, or even both sides of the heart valve. And then that lesion there on the heart valve is in the wrong place. It can cause irregular heartbeats, or it can cause rupture of something called a chorda tendinate, so that it allows that heart valve to become flappy and not be able to stop the blood from flowing in the wrong direction. This was just some slides about kidney involvement, but this is where I wanted to end up, because we started out on with walking and riding horses, but then somebody came up with automobile. But we have to see that the automobile was primitive, but then now we got a much more fancy automobile on this side here. I don't know which automobile you want, but I know which one I like, though. And this is that. But I'm talking about with lupus, where we started from and where we're headed is where we're trying to move. And then I want to move all the way to something like this. And this is that we can land that. This is that. I don't know if there's any questions or comments, but I think that I wanted to show you that lupus is understanding how lupus has really progressed from when I first started to now. And then we have more drugs that are available than what we had in the past. And then it looks like there's some more drugs are being studied for the future. All right, thank you very much.
Anybody have a question?
I had a question about IgG,
Okay.
and you had showed it at the top, going down to the C. Does it go backwards? Because lupus destroyed my immune part of my system.
Well, if you think about it, those IgG, or I'll just say immunoglobulins itself, are actually produced by the plasma cells and B cells. So if you can regenerate or redevelop those B cells, then and plasma cells, you may be able to regenerate that IgG. But I was thinking most people that we see that with IgG deficiency, they may have gotten it from conditions other than lupus. Lupus is not the only thing that causes it. And so far, it hasn't been very reversible. But if you got lupus that we see that have antibodies against the white blood cells in terms of your immune system, if you could control that, your body can make its own, or bone marrow can make its own B cells again, and you can regenerate those that antibody from those B cells once you get those new B cells available.
And lupus is diagnosed as Sjogren's syndrome?
I wouldn't say it can be. To me, it almost, if you call it Sjogren's, if you call it lupus, you might be saying two things that are very similar to each other, because that many people with lupus also have Sjogren's syndrome, and many people with rheumatoid arthritis also have Sjogren's syndrome. You can have Sjogren's syndrome independent of anything else, but it also can be associated with other conditions too. The Sjogren's syndrome has many of the same features that lupus has. They have the rashes. One of the reasons that is that the Sjogren's syndrome is also tend to be associated with the SSA antibody and SSB antibody, and both of those antibodies tend to cause rashes. So they can some of those same rashes can look just like that subacute cutaneous rash that we saw with lupus.
The rashes that you show,
I
always see them on people's faces. I get them on my leg.
Well, it can be. I try to pick some slides just to show there can be other places, but those rash I saw with the subacute cutaneous lupus, that was on the chest. You know, in adults, you hardly ever see that rash on the face of adult patients. but it's very common in pediatrics, very common in adults actually. Just that, and which can be any place. But it's not, but it tends to be affect the faces a lot more in adults than it does in children. So it's just that. So there's a little bit of difference in terms of childhood lupus versus adult lupus.
Anybody else?
Mm-hmm.
Oh, I have a question.
Yes.
So many new drugs on the horizon,
Mm-hmm.
and so many new drugs are just approved
Mhm.
during COVID. Whose responsibility is it? I see these commercials on TV all the time. Okay, are they for me or are they for the physician? Who are they
That's
for?
that the,
And are we supposed to ask you, or are you gonna? How are you gonna figure out with the variety now? I can't believe that I've lived this long to actually say this, because we've been around a long time,
Oh, yeah.
and it wasn't an easy journey, but we survived.
Mm-hmm.
So how do you know which medication to use with so many to
Well,
pick from?
yeah, that's an interesting question, and I don't think I have the answer for it yet because that, yeah, I have to admit I'm one of those that I like to wait and see it just a little bit because that I think some of these drugs that when they first come out you don't really know what the side effects are completely, and so that so that's my particular preference. But I think that when you're going to mention like different studies, I think it should be the physician that actually kind of mentions it. And it's that, and one of the reasons I say that because that, say if I have a patient that has a bad kidney involvement, I think I want to put him on something that I have a confidence that it's going to work rather than putting him in a study that I don't know if they're going to get the study drug or if they're going to get a placebo. So that's a little bit of question I have with that. But I think that that if we have a drug that we find that is especially good, and it's been out at least a year, I may decide to put some patients on it. But I'd rather lean more to the patients that are more easily treated with less serious conditions before I put them on the experimental things.
Do you treat pediatrics and adults?
I'm just adults because the pediatrics is a very. I used to do pediatrics a long time ago. So that's one of the. It was one of the hospitals we worked at where we didn't have pediatric rheumatology, so we had to learn it too. But I'm strictly adults now. Mm-hmm. Mm-hmm.
Well, but you
Mhm,
I
that's
learned
a-
something. I've been listening to you for years, and every year I
That's a-
learn something new.
Oh no, thank you. That's a.
Some of this may have been deep. I mean,
That's a.
catching on.
That's a.
But so grateful for all you do and for sharing with us today and taking your time. So join me in thanking Dr.
No, thank you. Thank you. Thank you. Thank you.
Alex.